post-discharge medications with their grades of evidence are reported as above. Aspirin, if not contraindicated. Clopidogrel, when aspirin is contraindicated. Aspirin and clopidogrel for up to 9 months. Beta blockers, if not contraindicated. And lipid-lowering agents like statins with diet control. ACE inhibitors, if there is evidence of congestive heart failure, ejection fraction less than 40%, diabetes mellitus, or hypertension. Studies which looked at statin use were reported first by Cannon in the New England Journal of Medicine in 2004. He compared use of pravastatin 40 milligrams and atorvastatin 80 milligrams and found a 16.6% reduction in percentage of events over a period of 30 months follow-up, which reached significance levels with p-values of 0.005. Reduction in major cardiac endpoints were shown in this classification. Reduction in all-cause mortality, relative risk of 28%, coronary heart disease-related death, myocardial infarction, death or MI, revascularization in greater than. Risk factor modification was also associated with improvement, and Ronwald's publication in Circulation in 2002 advised strongly on smoking cessation counseling, dietary counseling, and modification, cardiac rehabilitation. Heart failure due to systolic dysfunction. Heart failure is a very common health problem. Approximately 5 million Americans suffer with heart failure, and more than 550,000 new cases are reported annually. Over 1 million hospital discharges in the United States list heart failure as a primary diagnosis each year. The high prevalence places a large economic burden on the healthcare system. Despite many advances in therapy, the prognosis of patients with heart failure remain poor. Mortality rates are high, and patients discharged from the hospital with heart failure have high rates of readmission. The pathophysiology of systolic heart failure involves a process termed ventricular remodeling. This process is initiated by injury to the heart muscles from illnesses such as hypertension, myocardial infarction, or valvular heart disease. The response to myocardial injury, increased wall tension, and a fall in left ventricular performance includes activation of the neurohormonal systems, including the renin-angiotensin-aldosterone system and the sympathetic nervous system. This neurohormonal activation leads to myocardial fibrosis, myocyte necrosis, and progressive left ventricular dilatation with worsening systolic function. Systemic vasoconstriction and tachycardia lead to further deterioration in left ventricular function. Worsening of left ventricular function leads to the typical heart failure symptoms of fatigue due to reduced cardiac output, and dyspnea and edema due to pulmonary and peripheral venous congestion. These are echocardiographic images which demonstrate left ventricular remodeling. 1 week after an acute anterior septal myocardial infarction, left ventricular volume is increased and ejection fraction is reduced, as seen in the image on the left. 3 months later, without additional acute infarction, left ventricular remodeling has resulted in further dilatation of the left ventricle and further reduction in ejection fraction, seen in the image on the right. The following have been the drugs commonly used in management of a patient presenting with heart failure: ACE inhibitors, beta blockers, angiotensin receptor blockers, aldosterone antagonists, loop diuretics, nitrates with hydrolazine, digoxin, and neseritide, along with inotropic agents. Studies using ACE inhibitors as treatment for systolic heart failure were reported in the early 1990s. These studies showed consistent reduction in mortality in patients with New York Heart Association classification 2 and 3. When patients with asymptomatic left ventricular dysfunction were treated with ACE inhibitors, significant reduction in the development of heart failure symptoms and in hospitalization for heart failure was seen. A meta-analysis of 32 ACE inhibitor trials which enrolled over 7,000 patients revealed an absolute mortality reduction of 6% with significant improvement in symptoms and functional class. All ACE inhibitor drugs are felt to be beneficial in systolic heart failure. Beta blocker therapy was then studied. The rationale for this approach was based on observations that catecholamine levels are high in patients with heart failure, and the higher the level, the more severe is the condition. It is known that excessive catecholamines have deleterious effects on the myocytes, including inducing hypertrophy and apoptosis. Catecholamines also worsen ischemia and are arrhythmogenic. The MERIT-HF trial reported the experience using the cardioselective long-acting formulation of metoprolol. In these patients with systolic heart failure, significant reductions in mortality and hospitalizations was seen with metoprolol when added to ACE inhibitors. The result of the study showed total mortality and all-cause hospitalization was reduced from 38 to 32%, and total mortality reduced from 10.8 to 7.2%. The Capricorn study used the beta and alpha blocker carvedilol in post-myocardial infarction patients with reduced ejection fraction. Survival was improved with the use of this medication. There was a risk reduction of almost 23%, which reached significant levels. Carvedilol was also studied in the most severe heart failure patients whose left ventricular ejection fraction were below 25% and who were in the NYHA 3 or 4 class. In this study, called Copernicus, a very significant mortality benefit was seen with the drug. Mortality curves for carvedilol and placebo began to diverge as early as 3 weeks after initiation of therapy in this study. A study called the Comet trial compared therapy with carvedilol to treatment with short-acting metoprolol. It showed better survival with carvedilol. In summary, multiple trials have demonstrated improved outcomes with the use of beta blockers in patients with ischemic and non-ischemic cardiomyopathy, left ventricular dysfunction, and heart failure. Mortality benefits are in addition to benefits seen with ACE inhibitors. Beta blockers approved for the use of heart failure are carvedilol, bisoprolol, and sustained-release metoprolol. Angiotensin receptor blockers have been examined in several studies in patients with heart failure. Valsartan and candesartan have been found to improve symptoms and life expectancy in patients intolerant to the use of ACE inhibitors. Therefore, when angiotensin receptor blockers were added to ACE inhibitor therapy in the CHARM study, a small improvement in mortality was seen, although the incidence of hyperkalemia, hypotension, and renal insufficiency was greater. Aldosterone blockers are an important part of medical therapy for severe heart failure. The REAL study showed significant mortality benefit in functional class 3 and 4 patients when spironolactone was added to the ACE inhibitor therapy. In another trial, eplerenone, when added to ACE inhibitor and beta blocker therapy, was shown to improve survival in patients with myocardial infarction who were diabetics or who had heart failure.